Good morning, and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Lauren Hardin, and I am one of the co-chairs of PTAC, along with Angelo Sinopoli. Since 2020, PTAC has been looking across its portfolio to explore themes that have emerged from proposals received from the public over the years. After each theme, the committee releases a public report to the Secretary of HHS with its findings. In March, we had our public meeting on improving care delivery and integrating specialty care in population-based models. We plan to post the report to the Secretary on our website in the next week. A listserv will go out announcing the posting of that report. We also plan to post the June report to the Secretary on improving management of care transitions in population-based models in the next month. Rural providers face challenges with care delivery and approaches to address them, particularly in relation to population-based model participation. And this theme has come out throughout the previous PTAC theme-based discussions and in several submitted proposals. We know that this topic is also of interest to the Innovation Center at CMS. And before our first presentation of the day, we're very honored to have opening remarks from Dr. Liz Fowler, the Deputy Administrator of CMS and Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on healthcare and economic policy at the National Economic Council. From 2008 to 2010, she also served as Chief Health Counsel to the Senate Finance Committee Chair, where she played a critical role in developing the Senate version of the Affordable Care Act. Thank you so much and welcome, Liz.
Lauren, thanks. It's so nice to be here. Dr. Sinopoli, nice to see you and all the rest of the PTAC members, and also note that we've got a number of CMS Innovation Center folks who are eagerly listening in the audience to the presentations today. Just want to thank you for the invitation to provide some opening comments this morning, and it's great to be back for the third quarterly meeting of 2023. The first two quarterly meetings this year were very rich discussions, and the Innovation Center has been tracking closely a lot of these discussions. The specialty care integration meeting in March, and then, as you noted, the transitions of care meeting in June. Both of those meetings brought together deep subject matter experts who provided excellent thought-provoking presentations, and I expect these discussions on rural health to be more of the same. We know people in rural communities have a higher prevalence of chronic diseases like diabetes and COPD, as well as higher rates of unintentional injury and disability compared to their urban counterparts. And we also know that access to care is a particular challenge in rural communities. These disparities in access challenges are linked to many different factors that speakers over the next 2 days will explore. For example, only 12% of physicians practice in rural communities, and more than half of health professional shortage areas are in the U.S. are in rural areas. And over the last decade, many rural hospitals have closed, particularly in states that have not expanded Medicaid, and this has exacerbated the challenges around accessing care. Greater use of telehealth services, a promising way to improve care and access in rural areas, while positive, may be limited if broadband access isn't available. And finally, technology barriers that limit telehealth uptake, workforce shortages that have impacted providers and health systems across the country, but are particularly acute in rural areas, and other structural limitations have all led to a decreased uptake in value-based care models in rural areas. Supporting access to care in rural, frontier, and other geographically isolated communities is a priority for CMS. And we're working across the agency to think about and how to address these challenges. Last year, CMS finalized rules for rural emergency hospitals, a designation that would allow critical access hospitals and small rural hospitals to convert to REH status and receive enhanced Medicare reimbursement. And starting in January 2024, the Medicare Shared Savings Program will provide advanced infrastructure payments to new ACOs, and we hope that this will provide a bridge for entities to join the program, particularly in rural areas among practices and providers. Current and past models and initiatives at the Innovation Center also represent an extension of the CMS commitment to support rural health. We continue to administer 2 statutory demonstrations, the Rural Community Hospital Demonstration and the Frontier Community Health Integration Project, FCHIP. We also lead the Pennsylvania Rural Health Model, or PARM, which started in 2017 and will continue through 2024. Which is exploring the feasibility of care delivery transformation in the context of hospital global budgets. We have heard some hospitals have commented that the global budget hasn't funded all of their hospital transformation activities, but the model has been a catalyst to accelerate existing and build new community partnerships. And then 2 weeks ago, we announced the state's advancing all-payer health equity approaches or AHEAD model, which focuses on state health systems and transformation, and also includes a hospital global budget component. This model is open to rural health clinics and critical access hospitals. Additionally, the new primary care model we announced this summer has a strong focus on underserved communities and particular outreach and focus on community health centers. And we hope that those providers and practices and organizations who serve beneficiaries in underserved areas, including rural areas, will be coming into the model. And as some in the audience may know, in March 2023, we announced the termination of the Community Health Access and Rural Transformation, or CHART model, due to a lack of hospital participation. CHART was intended to innovate payment, increase access, and improve the quality of care and health outcomes in rural communities. While we were disappointed at this outcome, we also appreciate what we learned from our rural partners about this model and why the outcome wasn't what we wanted or expected. As the CMS Innovation Center continues to explore opportunities to expand our work to address the challenges faced by beneficiaries and providers in rural areas, we look forward to hearing from all of the speakers that PTAC has invited to this meeting. In particular, I know we have a handful of them who are participants in some of our models, and welcome them as well. I'll close by with a few general questions that CMMI is hoping to learn over the next couple of days. First, our teams are challenged by the many definitions of rural. How should it be defined for purposes of CMMI? What kind of providers count as rural, and which ones shouldn't count, and why? And second, what should we prioritize in a care delivery model for rural populations? Third, what are the changes to payment that are interesting to rural providers, or what flexibilities would they need to take on value-based care arrangements? For rural providers and practitioners that haven't been engaged in value-based payment models, what are some of the key factors holding them back? And finally, given lower patient volumes in rural healthcare settings, what does this mean for measuring the quality of care? How can we reliably measure the quality of care in rural communities? We are very grateful for the efforts that went into developing the presentations over the next couple of days, and look forward to learning more from all of you on how to solve the disparities in healthcare experienced in rural communities. We're eager and excited that our partnership with PTAC will help inform future innovations and actions in rural healthcare. So I'll stop there and turn it back over to you, and thanks very much for the chance to be here.
Thank you so much for joining us, Liz. We really appreciate your engagement and partnership and look forward to working with you over the next couple of days. For today's agenda, we will explore a range of topics, including challenges facing patients and providers in rural communities, approaches for incorporating rural providers in model design, provider perspectives on payment issues related to rural providers, incentives to increase rural providers' participation, and successful interventions and models for encouraging value-based transformation in rural areas. The background materials for this public meeting, including an environmental scan, are online. Over the next 2 days, you'll hear from many esteemed experts. We've worked very hard to include a variety of perspectives throughout the 2-day meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. I also want to mention that tomorrow afternoon will include a public comment period. Public comments are limited to 3 minutes each. If you would like to give an oral presentation tomorrow, but have not registered to do so, please email PTAC registration at norc.org. Again, that's PTAC, PTAC registration at norc.org. The discussions, materials, and public comments from the September PTAC public meetings will all feed into a report for the Secretary of HHS on how to encourage rural participation in public population-based models. The agenda for today and tomorrow includes time for the committee to discuss and shape our comments for the upcoming report. Before we adjourn tomorrow, we'll announce a request for input, which is an opportunity for stakeholders to provide written comments to the committee on improving care transitions. Lastly, I'll note that, as always, the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about how to submit a proposal online. At this time, I would like my fellow PTAC members to please introduce themselves. Please share your name and organization, and if you would like, feel free to describe any experience you have with our topic. First, we'll go around the table, and then I'll ask our members joining remotely to introduce themselves. I'll start. I'm Lauren Hardin, a nurse and Chief Integration Officer for HC2 Strategies. I've spent the better part of the last 20 years designing care management models under all of the ACO, BPCI, value-based payment initiatives, and was a founding member of the National Center for Complex Health and Social Needs, and have partnered with states, communities, health systems, designing models to meet the needs of underserved populations, and deeply working now in California with the Medicaid 1115 waiver, building connected communities of care deeply in rural areas. Angelo.
Thank you, Lauren. So, I'm Angelo Sinopoli. I'm a pulmonary critical care physician by training. Spent a lot of my career in an organization called Prisma Health, where I built and developed a large clinically integrated network there that served about 1.2 million patients across 2/3 of South Carolina. We had 5,000 providers in that network, and obviously in South Carolina spent had a lot of patients in very rural areas as well as urban areas, and so had a diverse experience there taking care of those patients. And most recently, I'm the Chief Network Officer for Upstream, and looking forward to the next few days. Jay?
Good morning, everyone. My name is Jay Feldstein. I'm originally trained as an emergency medicine physician. I practiced emergency medicine for 10 years and then spent 15 years in the health insurance world in government and commercial programs. And in the last 10 years, I've been the president of Philadelphia College of Osteopathic Medicine, turning out primary care physicians in both urban and rural settings.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer at UC Health for our Denver metro area. We're one of the largest healthcare systems in the Rocky Mountain region. I'm also co-founder of the Health Systems Care Innovation Center, where we partner with digital health companies to grow and scale their solutions to improve patient care. I'm a tenured professor at the University of Colorado School of Medicine and emergency physician by training, and co-author of an alternative payment model that was considered by this committee.
Good morning. My name is Jim Walton. I'm a general internal medicine physician. I started my career in Waxahachie, Texas at a private practice, and transitioned to develop rural health centers in Ellis County, and then transitioned into as a medical director of Baylor Community Care for about 2 decades. back to the programming. I served as a Baylor Healthcare System's Chief Health Equity Officer, and then transitioned into the CEO of a large primary care ACO in Dallas, Texas, serving both urban, rural patients in both in Medicare and Medicaid and commercial ACO contracts.
I'm Dr. Larry Kaczynski. I am the founder and chief medical officer of Sonar MD, a value-based company that for the last 10 years has been my focus. We bring risk-based, value-based solutions to gastrointestinal specialists in the commercial space. Of note is the fact that Sonar MD was the first PTAC recommended physician-focused payment model back in 2017. I look forward to the next 2 days.
Good morning. My name is Walter Lin. I'm an internist and founder of Generation Clinical Partners. We are a group of providers based in the St. Louis, Southern Illinois area that cares for the frail elderly in senior living organizations such as nursing homes and assisted living facilities.
Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas, and a medical director with One Medical. After 10 years in teaching residents and medical students, I shifted to Iowa Primary Care, where we started caring for older adults on Medicare and full risk payment models, and continue to serve as the medical director for our practices in Texas.
Good morning. My name is Chini Puluru. I'm a family physician by trade, most recently Chief Clinical Executive and Vice President of Clinical Operations for Walmart Health, where I powered the expansion of Walmart Health clinics as well as the integration of their national telehealth platform and the transformation to value-based care across the enterprise. Prior to that, I served as Chief Clinical Executive for DuPage Medical Group, now called Dewey, and their subsidiary medical services organization, leading their value-based care service expansion as well as physician engagement. Thank you.
Good morning. I'm Terry Lee Mills. I'm a family physician, and I'm Senior Vice President, Chief Medical Officer at Community Care, a regional health system-owned provider, health payer in Oklahoma. We operate in the Medicare Advantage, commercial and marketplace exchange space, where for 30 years we've offered total cost of care, quality-directed, capitated models in all three of those markets. I came up through medical group leadership in a variety of integrated health systems, leading primary care transformation, including operating in a whole variety of CMMI innovation models over 25 years.
Thank you so much, everyone. And now we'll turn to our first presentation. So 3 PTAC members have served on the Preliminary Comments Development Team, or PCDT, which has worked closely with staff to prepare for this meeting. Jay Feldstein was the PCDT lead with participation from Jim and Josh. I'm thankful for the time and effort they put into organizing today's agenda. I think you'll find it sets a very great foundation for our discussion today. We'll begin with the PCDT presenting some of the findings from their analysis. Additional background information materials are available on the ASPE PTAC website. PTAC members, you will have an opportunity to ask the PCDT any follow-up questions afterwards. And now I'll turn it over to Jay.
Thank you, Lauren. I'd like to just thank the staff of ASPE and NORC for their hard work and support, and my fellow PCDT team members and the PTAC committee for their contribution and support. Myself and Jim and Josh have a special affinity and commitment to rural healthcare, as all 3 of us have practiced and are committed to rural healthcare. Jim practiced rural health medicine in Texas. We actually opened a medical school in rural South Georgia with a population of 15,000 people. And I know Josh is committed as well to rural health care in the state of Washington. So this is really an exciting topic for all 3 of us and for all members of the PTAC committee. So over the next 2 days, what we're looking to do is to examine challenges. The first one will be advancing the slides and reading them at the same time. Facing patients and healthcare providers in rural communities. Identify care delivery models that are effective in addressing patient needs, improving outcomes, and encouraging value-based transformation in rural areas. And explore options for encouraging participation of rural providers in population-based total cost of care models and other alternative payment models. And to identify financial incentives and mechanisms to increase participation of rural providers in alternative payment models. Rural providers face unique challenges and have been less likely to participate in accountable care organizations than other population-based models. The Centers for Medicare and Medicaid Services and the Center for Medicare and Medicaid Innovation have developed several models and programs designed to encourage value-based transformation in rural areas. PTAC has deliberated on the extent to which 28 proposed physician-focused payment models met the Secretary's 10 regulatory criteria. 11 of these proposals either included or targeted rural populations. And the goal for this meeting is to better understand these challenges and lessons learned from models and programs that have sought to address them. As part of the overview, we'll explore the definitions of rural care, challenges affecting rural patients and providers, challenges affecting rural participation in alternative payment models, and innovative approaches for supporting rural value-based care transformation, and lessons learned about rural participation in alternative payment models. There are a variety of definitions for determining what constitutes a rural area. Definitions are used for various purposes such as grants, public policy, and research. Criteria include geography, population size, population density, proximity to metropolitan areas, and geographic remoteness. PTAC is using the following working definitions for this presentation. The Office of Management and Budget identifies metropolitan areas as counties with 50,000 or more people, and rural areas as counties with fewer than 50,000 people. The U.S. Department of Agriculture has 9 Rural Urban Continuum Codes, or RUC codes, that can be used to further identify differences in rural counties based on population size and proximity to metropolitan areas. PTAC is using the following working definition of rural providers. Rural providers are providers including independent practitioners and other types of providers that are physically located in rural areas. PTAC is aware that some rural areas also have access to providers that are located in urban and suburban communities. The key takeaway here is how do we define them, how do we measure their success, and how ultimately do we reimburse them in payment models. When we look at geographic distribution by rural access by RUC codes, you can see that 15% of the U.S. population, or close to 46 million lives, are people in rural areas. 63% of U.S. counties are designated as rural areas, and some counties include both rural and non-rural areas. If you look at the scale, non-rural or cities at 1 are represented by the rose-colored geographic areas, and as we get to dark blue, they become more rural, with 9 being the most rural areas in America. Rural areas vary based on population size and proximity to metropolitan areas. Half of all rural counties have 2,500 to 19,999 residents, and a third have less than 2,500 residents. Half of all rural counties, 48%, are not adjacent to metropolitan areas. The bottom line is rural areas are not monolithic. Therefore, effective delivery models, financial incentives, and payment methodologies may vary depending on the type of rural area and the type of rural provider. Rural areas with a shortage of providers may experience different challenges compared to rural areas with low patient volume or insufficient competition among providers, relative to having sustainable financing, measuring performance, and being able to participate in APMs. There are regional differences among rural providers as well, according to population size and adjacency to metropolitan areas. Nearly half of all rural counties in West North Central region have less than 2,500 residents, and nearly 2/3 of all rural counties in the West North Central region are not adjacent to metropolitan areas. I want to highlight on this slide the Mid-Atlantic states, New Jersey, New York, and Pennsylvania. The percentage that is completely rural, less than 2,500, urban, non-metro population, or RUC counties 8 and 9, are less than 9%. Not adjacent to metropolitan areas, which are RUC codes 5, 7, and 9, is 20%. Now compare that to the West North Central. 49% have areas of less than 2,500 population basis, and 64% are not adjacent to a metropolitan area. So there's tremendous variation across the country. There's also tremendous diversity among rural providers. Rural providers differ in the services that they offer and in statutory requirements. Some rural providers have special payment rates and methodologies created by statute. For example, critical access hospitals provide 24-hour emergency care services, whereas rural health clinics may be limited to providing a specific type of primary care. And rural healthcare centers and critical access hospitals are not paid by service codes, so they are not accustomed to coding and billing as the same way as other providers, which makes measurement and reimbursement sometimes difficult. Additional differences between rural and urban areas. Compared to non-rural counties had lower income on average, less than $9,000 per average per capita in the U.S., and Americans living in rural areas are more likely to live below the poverty level. There's a higher uninsured populations. Rural areas had larger proportions of adults under the age of 65 without insurance. It's an older population. 17.5% of the rural population is 65 and over, compared to 13.8% in urban areas. And most importantly, there is decreasing life expectancy in rural counties. We'll explain in more detail the life expectancy differences in later slides. Compared to non-rural counties, rural counties had fewer primary care providers, 37.9 versus 52.9 per 100,000 people, fewer specialists, 46.5 specialists per 100,000, while urban areas have 146.4 per 100,000. And a theme that will come up during the course of the presentation is reduced broadband access. Less than 70% of rural households have access to high-speed internet, compared to 85% of households in large metropolitan areas. In fact, when we were doing research for this theme-based discussion, some potential subject matter experts in rural areas could only be reached by phone or fax because they had no internet access. And there are lower Medicare Advantage enrollment in rural areas compared to metropolitan areas. That has basically quadrupled since 2010, and now there are close to 1 million Medicare Advantage beneficiaries living in rural areas. Just a graphic of the adjusted death rates by the urban-rural classification in the United States over the last 10 years, and you can see there is a discrepancy between rural death rates and urban death rates. More importantly, when you look at age-adjusted death rates for the 10 leading causes of death by urban-rural classifications, the greatest discrepancy in death rates are in heart disease, cancer, and chronic lower respiratory diseases. When we look at an overview of issues affecting rural healthcare systems, settings, providers, and patients, obviously there are going to be economic, social, and environmental challenges. Accessing federal resources, poverty, lower health literacy and educational attainment. On the patient side, there's higher rates of obesity, substance use, and chronic disease, complications due to less health insurance and access, higher rates of unintentional injury, more older adults. In the provider setting, there's lower patient volume and provider revenues, more publicly and uninsured patients, complex patient populations, workforce shortages and an aging workforce, and a higher workload burnout, as well as limited transportation options for patients and insufficient ancillary healthcare services. When we look at the intersection between patient issues and provider issues, lower income affects both. There's a mismatch between infrastructure for broadband access, health information technology, provider mix, which is reflected in a lack of specialists, and a lack of community-based organizations and resources, and patient complexity. Rural doctors are seeing urban-level disease with rural-level resources. Rural patients' higher rates of obesity and substance abuse, as well as the higher proportion of older adults with limited access, leads to decrease in services and specialists with poor health outcomes. And the challenges providers face with addressing the needs of complex patient populations while having limited support staff because of workforce shortages often leads to a higher workload and burnout rate. Rural healthcare settings, lower patient volume frequently results in inadequate income streams necessary for providers to sustain their practice, which forces them to shut down. The unstable finances also limits their ability to participate in APMs and population-based total cost of care models. Let's look at some of these in greater detail. Complex patient populations, rural areas tend to have higher rates of behavioral health conditions, substance abuse, and older adults, as well as higher disease burden compared to non-rural areas. The higher rate of uninsured and publicly insured patients under the age of 65 were 2.5 to 4 times more likely than their urban peers to be uninsured. And rural hospitals have a 20 percentage point higher rate of Medicaid patients. Lower patient volumes. Low volumes can affect financial viability and reduce reliability and validity of performance measurement results and impact providers' ability to participate in CMS quality programs. 47% of rural hospitals have 25 or fewer staff beds, and over 100 rural hospitals closed between January of 2013 and 2020. 11 rural hospitals have closed in 2023, and over 600 rural hospitals are at risk of closure for this year. Rural PCPs tend to make 5% less than their urban counterparts. Now, the Consolidated Appropriations Act of 2021 established rural emergency hospitals as a new Medicare provider type to address the large number of rural hospital closures during and prior to the COVID-19 public health emergency. Rural emergency hospitals are required to provide emergency and observation services and may provide other outpatient services based on the needs of the community. They received enhanced Medicare payments for certain outpatient services and an additional monthly facility payment. Workforce shortages, patient to PCP ratios in rural areas, 40 PCPs per 100,000 compared to 53 in an urban area, higher workloads, challenges building economies of scale due to limited financial resources in rural areas can challenge technological integration and other innovations. And less health information technology infrastructure. Rural areas experience lower HIT adoption rates due to limited financial resources and inconsistent broadband access. Approximately 43% of rural healthcare centers report that cost for health information technology improvements prevents their participation in ACOs. Compared to non-rural areas, rural areas have fewer PCPs and specialists per 100,000. When we look at the specialists, 46 per 100,000 as compared to 146 in non-rural areas, with a large discrepancy in cardiovascular disease. There's only 1.1 per 100,000 in rural areas compared to 4.27 in non-rural areas. Whether this fact is causative or an association for the increased death rates seen in rural areas for cardiovascular disease remains to be seen. Gastroenterology specialists, 0.47 per 100,000 compared to 2.93, and neurosurgery, 0.17 per 100,000 versus 1.3 in non-rural areas. So what are some of the opportunities for addressing rural workforce challenges? Well, due to the workforce shortages in rural communities, there's increased provider burnout and turnover, there's increased difficulty with recruiting and retaining providers, and there's limited access to healthcare training and education in rural areas for ancillary staff. Some of the strategies for addressing rural workforce challenges through the use of telehealth. ACOs can provide resources to support telehealth. They can help share financial risks and it can be cost effective and help rural providers adopt higher value telehealth applications. Bonus payments for rural health providers to develop their telehealth infrastructure, incentives for rural providers to increase the proportion of telehealth visits, and funds to provide rural patients with access to necessary telehealth technology, cell phones, facilities with tablets, and again, increased broadband access. In terms of giving rural providers, they encounter challenges when implementing and using health information technology and data analytics. They have a lack of financial resources. Again, 43% of rural health centers reported costs for health information technology improvements prevented their participation in ACOs. And many providers lack training on data analysis and decision support systems, as well as having the support staff help to use health data information. And patients may not engage in health information technology due to a lack of broadband access or low digital literacy. Some of the strategies for addressing this infrastructure challenge are funding for health information technology infrastructure, providing technical assistance, and value-based incentives for health information technology engagement. Rural providers tend to participate in APMs at a lower rate than their metropolitan and non-rural counterparts, and physicians participating in advanced APMs in rural areas are most commonly in primary care specialties, family practice, and internal medicine. Again, the challenges affecting rural providers to participate are financial resources and risk management. They lack the capital to finance the upfront cost of transitioning to APMs. They're averse to financial risk or lack reserves to cover potential losses, and they treat too far Medicare patients to justify investments in APMs, and lower patient volumes result in less predictable spending patterns, heightening the financial risk. They're less able to control the cost of care because patients are often referred elsewhere for tertiary care, and their lower patient volumes render less predictable spending patterns. They're unable to conduct data analytics or financial modeling needed to provide value-based care. The complexity and cost of EHRs or lack of high-speed internet hinder EHR adoption, and the lack of EHR interoperability and staff training, as well as weakness of health information exchange between providers inside and outside the community, just are continued challenges for the adoption of data and health information technology. And again, staff resources and capabilities. They lack staff members capable of managing the transition to or participate in APMs. There's a lack of capital to manage building a population-based, team-based approach for care coordination and case management, and a general overall lack of awareness of APMs. Again, the design and availability of models. There are limited APM options due to models participation restrictions, whether geographic, provider type, and volume, a lack of nearby ACO or models appropriate for providers in rural, shortage, or underserved areas, economies of scale, and the potential need for low volume adjustments. They struggle to adapt to changing model rules and regulations. So the challenges faced by rural providers for total cost of care models are attribution, panel size, validity of outcome data given limited information technology infrastructure and smaller populations, the ability to take on risk, relevant performance measures, and quality performance measurements. For example, small panel sizes limit rural providers' ability to calculate reliable and valid performance measurement results. Types of care are most difficult to provide in rural communities include lack of post-discharge follow-up due to workforce availability and transportation issues, decreased access to mental health and substance abuse disorder treatment, fewer gastroenterologists, general surgeons, radiation oncologists, and other specialists, and limited access to ancillary service providers, home health care, diagnostic testing, and dialysis. Some of the approaches to address the needs of rural communities include audio and video visits, including telehealth, co-location of healthcare services, leveraging pharmacists as care providers, increasing value-based payment models in rural hospitals, and coordination with community-based organizations supporting nutrition and housing, etc. Strategies included in effective models that drive value-based care in rural areas include promoting behavioral health care services, supporting and encouraging care coordination across providers, improving specialty integration, and expanding care networks or performing new entities. Financial incentives to drive value-based care transformation among rural providers include providing startup funding for incentive coordination of care, provide a fixed upfront payment regardless of patient volumes to increase access to care and specialty care, quality incentives to drive value-based care transformation among rural providers, payment tied to performance on quality measures, adjust Medicare fee-for-service payments based on performance against a set of quality measures relative to their peers' performance, because performance impacts future payment adjustments. Challenges affecting rural providers' participation in performance measurement. Low case volumes place limitations on the calculation of reliable and valid performance measurement results. Several CMS value-based programs exclude providers from public reporting based on low care volumes. Staff shortages, as well as limited funds and other resources, limited staff with experience performing data extraction and analysis, as well as using measurement results to inform quality improvement efforts. And rural patients tend to be disproportionately impacted by health conditions, making performance comparisons between rural and non-rural settings difficult. Measures should not be used to evaluate rural providers' performance. For example, measures of cost should be used with caution, because some rural providers do not have access to lower cost treatment options or may encounter higher supply chain costs compared to non-rural providers. Strategies to ensure that rural relevant measures appropriately measure the performance of rural providers would be to tailor performance measures to the type of rural provider or healthcare services offered, modify measurement approaches for rural providers, use risk adjustment to account for differences in risk factors within and across rural patient populations. Need to consider how measuring the success of rural providers might differ from measuring the success of non-rural providers. One example would be emergency department utilization, because EDs are a critical source of after-hour care in rural markets. So reducing ED utilization may not adequately reflect value-based care transformation in rural markets. And again, potentially identifying other measures related to retention of rural providers in APMs and shared savings. Examples of quality measures used in prior APMs that target rural providers include inpatient and ED visits for ambulatory care sensitive conditions, hospital readmissions, ambulance transports, patient experience with care, primary care and behavioral health integration, influenza vaccination, screening for depression and follow-up plan, and rate of adults with preventative care visits, care coordination and care transitions, and substance use. Use of pharmacotherapy for opioid use disorder, use of opioids at high dosage in persons without cancer, and risk of continued opioid use. The National Quality Forum Measure Applications Partnership Rural Health Work Group suggested that rural relevant measures should be NQF endorsed, resistant to low case volumes, and address care transitions. Now, what are some of the lessons that we've learned from CMMI models that targeted or included rural participants? Several CMMI models have either targeted or included rural participants. The models use a variety of payment mechanisms, including prepaid shared savings per beneficiary per month payments, global budgets, fee-for-service payments, and population-based payments, bundled payments, and performance-based payments. Specific lessons learned include establishing longer on-ramps for rural practices interested in APM participation, developing APMs that specifically target rural settings, identifying suitable risk-adjusted quality measures, providing risk protection caps on risk exposure, extending bonus payments for new advanced APM participants, and decreasing qualifying participation thresholds for rural providers operating under APMs. Some selected lessons learned from CMMI models relevant to opportunities for rural provider participation. include the Frontier Community Health Integration Project, or FCHIP, demonstration, where increased payments for Part B ambulance transports and telehealth origination services increase patient satisfaction with telehealth. The Vermont all-payer ACO model provided upfront funding and limited downside risk. It was noted that different attribution mechanisms may be needed in rural communities to achieve scale. The Pennsylvania Rural Health Model, which was a creation of the Rural Health Redesign Center Authority, helped foster relationships among participants, payers, and partners. And although global budgets provided stable cash flow, participants and payers found it challenging to monitor global budgets. Preliminary Medicare per member per month spending is below the national average for rural hospitals, and 80% of participants improved avoidable utilization, and 83% improved their hospital-acquired condition reduction scores. The Rural Community Health Demonstration showed that rural community hospitals may need support to update older capital infrastructure, and the Next Generation Accountable Care Organization model, serving rural areas, used care management strategies such as telephonic engagement and embedded care management staff. Additional learnings include the Community Health Access and Rural Transformation Model, or CHART, which attempted to increase financial stability for rural providers through new reimbursement processes that provided upfront investment and predictable capitated payments, and removed regulatory burden by providing waivers that increase operational and regulatory flexibility. Unfortunately, this model was drawn this past year due to the feedback from model stakeholders as well as lack of hospital participation. The Medicare Choices model was actually for palliative care, which increased funding for transportation, allowed outcomes between rural and non-rural beneficiaries to be equal for end-of-life care. The Maryland all-payer model, hospital leaders in more rural or economically disadvantaged areas reported that they would not be able to attract or retain enough hospitalists and certain types of specialists if they did not employ those physicians. And the Accountable Care Organization investment model, which included upfront payment of shared savings, encouraged ACOs to form in areas with greater healthcare needs and less access to accountable care. And as of 2020, 14 of the 47 AIM participants remained in the Medicare Shared Savings Program, and the ACOs remaining in the program were larger and served less rural markets. So in summary, the experience with rural providers' performance in APMs showed that the ACO investment model decreased spending and maintained or improved quality of care in rural and underserved areas. Maryland's total patient revenue model, which was a global budget for rural hospitals, led to reductions in outpatient utilization, but not inpatient utilization. And early results of the Pennsylvania rural healthcare model stated earlier show that preliminary Medicare PMPM spending is below the national average for rural hospitals. In addition, 80% of participants improved utilization and 83% improved their hospital-acquired condition reduction scored, and 100% maintained their CMS admission rates. The Medicare Shared Savings Program inclusion of rural providers, and this program has been going on since 2012, is a voluntary program that encourages groups of doctors, hospitals, and other healthcare providers to come together as an ACO to give coordinated, high-quality care to their Medicare beneficiaries. Participants must have at least 5,000 attributed Medicare fee-for-service patients and agree to participate for at least 5 years. FQHCs, RHCs, and CAH are eligible to join an ACO under the MSSP, and FQHCs, RHCs, and some CAH are also eligible to become their own ACO under MSSP. As of January of 2023, 467 CAHs, or approximately 35% of all CAHs, and 2,240 RHCs, approximately 51% of all RHCs, were participating in an MSP ACO. Some of the lessons learned with the Advanced Investment Payment IAP and the new MMSP payment option is that rural ACOs participating in MSSPs were less likely to switch to a two-sided risk than urban ACOs, and some of the ACOs remaining in the AIM served less rural areas. CMS is offering a new payment option, the Advanced Investment Payment, to encourage ACOs to form in rural and underserved areas. The AIP offers eligible ACOs an upfront payment of $250,000 and 2 years of quarterly payments to build the infrastructure needed to succeed in MSSP and promote equity by holistically addressing beneficiary needs, including social needs. The AIP will be recouped from the ACO's shared savings. If there are no shared savings, as long as the eligible ACO continues to participate, monies will not be recouped. So what we've tried to do today with our presentation is to set the table for the next 2 days and to focus on the challenges facing patients and rural providers in rural communities, what the provider perspectives on issues related to rural provider participation in population-based models, the challenges with measuring rural providers' performance in APMs, some of the approaches for incorporating rural providers into population-based total cost of care model designs, incentives for increasing rural providers' participation in population-based models, and successful innovations and learnings and models for encouraging value-based transformation in rural areas. We look forward to a great discussion over the next 2 days and great panels and great subject matter experts. Thank you.
Thank you so much, Jay. Jay, Jim, and Josh, excellent work. We really appreciate all of this foundational research and work on summarizing this really important topic. I'm going to turn it briefly to Angelo for one question. Committee members, if you can hold your questions until we have our broad discussion later in the day. Angelo.
Yes, so I'll echo what Lauren just said. Just congratulations to you and the other PCD members. It's just an amazing amount of work that had to go into this and an amazing summary that's going to really set the stage not only for the next couple of days, but I think for next year work. So really good, and congratulations on that. I only had one clarification. So early on in your slides, as you were describing the rural environment, there was a specific use of the word independent physicians. And so I wondered if there's any data or differentiation between an independent physician or a physician that may be employed by a local delivery system or yet a distant regional healthcare delivery system that's providing them resources. Is there any data that discriminate between those?
In terms of the ratios of PCPs per 100,000?
Outcomes.
Or not in terms of outcomes. We haven't been able to find anything yet.
Thank you.
I want to thank you all again very much. We look forward to diving into more discussion. At this point, we're going to take a break until 10:30 a.m. Eastern. Please join us then. We have a great lineup of presenters today. Our first panel discussion on challenges facing patients and providers in rural communities. We'll see you at 10:30.
Produced by the U.S. Department of Health and Human Services.